Thank you, everyone, for joining us this evening. We are excited to have Dr. Jonathan V. Wright and Dr. David Rosensweet share their expertise in menopause and andropause as a preview for the upcoming Improving the Health and Happiness of Your Patients with Bioidentical Hormones workshop, taking place on December 17th in Las Vegas at the A4M 25th Annual World Congress. Please note that this webinar will last for approximately 1 hour, and all attendees are on mute. However, we would still like this session to be interactive. So if you have any questions, please type them into the chat box, and I will read them aloud for the doctors to answer at the end. Now, before we jump into the case study presentations, I would like to quickly introduce both of our experts. A Harvard University and University of Michigan Medical School graduate, Dr. Jonathan V. Wright is a pioneer in research and application of natural therapies to promote longevity and healthy aging. In the early 1980s, Dr. Wright was the first in the United States to prescribe comprehensive hormone replacement therapy using hormones identical to those found naturally in young humans, rather than hormones from pregnant horses and synthesized in factories. This therapy, bioidentical hormone replacement therapy, or BHRT, is now used nationwide by millions. Recognized by many as the father of BHRT, Dr. Wright regularly lectures on basic protocols for natural hormone replacement therapy, advanced aspects of therapy, ensuring safety during treatment, ways of optimizing treatment, and many other topics from his many years of clinical practice. Internationally known for his books and medical articles, Dr. Wright has authored or co-authored 13 books selling over 1.5 million copies, with 2 texts achieving best-selling status. Since 1996, he has written a popular monthly newsletter emphasizing nutritional and natural-based medicine with a wide-reaching distribution. Dr. David Rosensweet has been in private holistic practice all over the country since 1971. Dr. Rosensweet has had offices in New Mexico, California, Colorado, and Florida. Dr. Rosensweet is an expert on menopause and natural hormones. He teaches treatment of women in menopause with bioidentical hormones to physicians. He also leads an ongoing seminar, The Healing Process. Dr. Rosensweet currently has a practice in Naples and Sarasota, Florida, and does consultations with patients and physicians all over the world. Drs. Wright and Rosensweet, I will now hand the conversation over to you.
Hello, everybody. It is David Rosensweet.
Oh, I apologize for my pronunciation.
Yeah, no problem.
David.
And hello, this is Jonathan Wright, and the only reason we have the middle initial in there all the time is that there is both a veterinarian and a university urologist with the same first and last name. So I just stick that in there because we keep getting dog food samples and stuff like that, and we would prefer not to.
Okay. So Dr. Wright, would you like to begin?
Oh, okay. Well, I didn't know until a few moments ago that we were going to start with case examples, but we will do that. Now, just before I do, though, I should mention that this is not only going to be a seminar which talks about some of the fine details of things that might happen once in 100 times, but you better be aware of it, that sort of thing. But it also is going to teach the basics. And since David and I have a combined whole bunch of years of experience, we will definitely be going over the basics, but we'll definitely be going over some of the things that you won't see very often, but when you do, gee, be good to know what to do about them. So anyway, I think there's a PowerPoint, or as it's previously called, a slide on the screen, and what we should go to is the one that says on the top of it, testosterone hyper-excretion and the use of cobalt chloride. This is a very occasional thing here. This is a fine detail. Have we got it? Okay, well, if we do, as you can see on that PowerPoint, it says all steroids susceptible to hyperexcretion. What does that mean? What that means is that the enzymes in the liver sometimes go a little bit faster than they should, and they dump most of the steroid hormone, and it could be, as in this case, testosterone, or we've seen it happen with cortisol and estrogens, particularly estrogens. They dump most of it into the urine and leave very little behind. And so one wonders why one has to keep increasing the dose to get things done. Well, it's because the liver is dumping all the hormone. Well, here we are. A gentleman started testosterone, 75 milligrams a day. Now, this is rubbed in transmucosally, and we'll be explaining about transmucosal versus transdermal and that sort of thing. It does say transdermal on the PowerPoint. I have no idea who put that there because transdermal is not as effective as transmucosal, and it has the date when he started. But anyway, he started 75 milligrams a day. And notice that even with this amount of testosterone, which is pretty good amount, his free testosterone, oh my goodness, it was well below median, wasn't it? 25.2, I think. By the way, we're on the PowerPoint that says serum and 24-hour urine results in June. It was well below median with 75 milligrams, which is not usual. And the total testosterone, the total testosterone, next slide is right, or next PowerPoint, actually. You know, I learned that from my grandchildren. They said, Grandpa, what's a slide? And I explained to them. And they said, no. That's old stuff. I saw a slide shower in a museum. These days we do PowerPoints, not slides. Nothing sliding around. Okay, that's a digression, but I sort of had to go there to explain why I call them PowerPoints in honor of my grandchildren. Anyway, the total testosterone, well below median, with 75 milligrams, excuse us. So we did the 24-hour urine test to see how much was coming out. And look at that. The normal range is 20 to 200. And this fellow was putting out 282. So his liver was dumping too much of his free testosterone into his urine. And of course, that wouldn't do him much good. Might do some of the male fishes some good, but not him. All right, now let's go to the next PowerPoint, please. And my apologies for not having said that last time. Okay, now next one. Oh, I'm sorry. On the last PowerPoint, it said at the bottom, patient started cobalt chloride, 375 micrograms per drop, 3 drops a day, which is within a safe range. And on that next PowerPoint where it says serum and 24-hour urine test results at the top, 7 months later, please notice, let's skip down to the 24-hour urine, that instead of 282, with a usual output range of 20 to 200, he's now down at 195. Now, I got to admit that that's still high normal, but take a look at his free testosterone now. It's climbed from 25 to 119, and his total testosterone is up to 633, and both of these are a lot closer to the midpoint than they were before, and it wasn't due to any change in the cobalt. One might have thought, if one had not done the 24-hour urine, one might have thought, oh my goodness, let's just increase his testosterone from 75 milligrams a day to 100 milligrams a day or 200, and let's get that total and free testosterone up. And as you can see from that prior PowerPoint, what would have happened, he would have continued dumping it all into his urine. It seems that cobalt regulates how much of the various steroid hormones is excreted, and at the seminar, when we'll have more time, I can explain exactly which enzymes that it works on to get this job done. But the point is that every once in a while, you're going to run across somebody like this who is dumping too much of one or another steroid. It's hardly ever all the steroids. It's usually this one or that one, and I don't know why. You can run into someone who's dumping all these steroid hormones into the urine, not retaining too much. And why isn't the treatment working? Oh dear, that person needs some cobalt. So that's that particular PowerPoint, a small set of PowerPoints. Are we going to go back and forth and have Dr. Rosensweet do a case, or am I going to do another one? Where are we?
Well, continue.
Okay.
If you have another case, why don't you go ahead and do it, Jonathan?
Yeah, okay. Thank you, sir. Okay, well, the next PowerPoint says webinar case example number 2. Imagine that. I just did number 1. And it tells you on there which of the presentations it will appear in. And by the way, sorry about this, folks, but there's many other cases, too, that we'll be bringing up. But in this one, insulin resistance and diabetes 2. We all know what that is. And what are the clinical and laboratory correlations? Well, we all know that tyrosines and dupetrons and lensopacities, those all have a higher degree of correlation with type 2 diabetes. And the laboratory correlations you can see down here at the bottom. Here's an oddball one, though. It's the last one from the bottom. One of my first professional papers published in 1979, and yes, I did go to school back in the dark ages, as my grandkids say, had to do with hair mineral analysis. And for whatever reason, I had tripped over the fact that if a hair mineral analysis all at the same time shows high calcium, magnesium, and zinc, that person is probably type 2 diabetic or pre-diabetic. I don't know why, but there is a test out there, the Kraft prediabetes test, that will absolutely nail a pre-diabetic 25 years before it ever happens. You'll hear about that in one of the presentations. So anyway, that's another correlation. But here's the point, I guess. We always have to suspect hyper-aromatization in us guys. Why? Because we all know that high insulin signal turns on that little aromatase enzyme. And how many people are diabetic or pre-diabetic? Well, if we can actually believe the CDC, they claim that slightly over 100 million Americans are pre-diabetic or type 2 diabetic. And by the way, that's very easily determined by a Kraft prediabetes test, even if you're 19 years old. And the pre-diabetic and the diabetic individuals are the ones who are going to turn on that aromatase enzyme. And if there's over 100 million of us, gee, that's almost 1 in 3 people. So 1 in 3 men we're going to be working with are potential hyper-aromatizers. Ooh, and we don't want to let that go on for very long, do we? That extra estrogen for that guy, well, might not give him so-called man boobs right away, but it's probably going to monkey with his prostate and stuff like that. So what I'll do to try to find that, as it says here, is here we are with the 24-hour urine collection again. Now that measures the testosterone, but the free fraction only. And the free fraction is what's active and, of course, what's available to be aromatized. And it measures all the free estrogens. And that's why the urine test, folks, because you cannot. You tell me where you can order a serum-free estrone or a serum-free estradiol. And even if you could order a serum-free estriol, another PowerPoint, and it'll come up somewhere during the seminar, goes clear back to the 1970s, and what it proved, and you'll see at the seminar how it proved it, is that the half-life of estriol in serum ranges between approximately 4 to 5 minutes and a little over an hour. And after that, it's gone. So you can't find, even if you had a free estriol test, it wouldn't tell you very much. But the urine gets all the free fractions of estrogens. And then what you want to know is, as it says further down the PowerPoint, if the testosterone is below median for men, but the estrogen is above median for men, oops, that guy's hyper-aromatizing. Now, some of the people I work with say, well, let's skip that Kraft prediabetes test that's on the 4th bullet point there. I'm just going to assume I'm hyper-aromatizing from this data here, and okay, let's take care of me as a pre-diabetic, go on the paleo diet, et cetera, et cetera. But I work with enough engineers who say, well, gee, I want total proof. So what are we going to do? My testosterone is below median, my estrogens are above median, it's all the free fraction, I might be hyper-aromatizing, but I want proof. I'll say, cool, run the Kraft prediabetes test, which we'll be talking about at the presentations. If you haven't heard about that, it's a very well-researched, very established test, which will tell you years in advance. And now let's go to that very last PowerPoint, because I got to shut up and let Dr. Rosensweet carry on. That very last PowerPoint. And notice this guy's estrogens compared to the normals on the right. And notice his androgens. His testosterone is only 38, which is well, but somebody should have circled that in red. I don't know why they didn't. But anyway, his testosterone itself is only 38.8, and the median is about, as you can see, 20 to 200. That's 110. And yet look at his estrogens. All 3 of them that are circled are higher than the upper end of the range. And the 4th one, the estriol, is well above median, where his testosterone isn't. So there's a testosterone high hyperaromatizer. That man is pre-diabetic. And if we do, and I know none of us do, but if we do the knee-jerk thing that some of our men's clinics in Seattle area do, oh, here you go, guy, here's your testosterone prescription, and have some anastrozole while you're at it so you won't hyperaromatize. We're actually doing that man a very bad disservice, because all we're doing is allowing his tendency to diabetes to progress and not doing a blinking thing about it. We're just cutting down on hyperaromatization, but all the other processes that lead to type 2 diabetes continue, and we're much better off finding those pre-diabetic men and then helping their overall body chemistry just slow down on hyperaromatization as they work their way out of their pre-diabetes. So anyway, that's all I've got with these two case presentations. Sorry for talking so fast, but thank you for listening.
Very interesting. All right. You turning this over to me, Giselle? What let's see. What I'd like to talk about is a series of cases, and what I want to ask the question is, what are the optimal estrogen treatment dosages? And let's see if I can get this to operate properly. And we're going to look at a group of women, actually over 50 tests, 24-hour urines of women who titrated to what they thought was really good symptom alleviation. For example, they had hot flashes, and they alleviated those hot flashes, and they felt quite content about the improvements after being treated with bias. Well, let's examine how much bias they actually applied. And I'm going to have you tell you a lot more about this and give you evidence that when dealing with bias, because of the different strengths of the estradiol and the different potencies of estradiol and estriol, we've got to come up with a system to really calculate how much strength they were administering, especially when you're changing ratios, let's say from 80-20 to 60-40. If this sounds foreign to you, I promise to go into full detail and teach you how to do this. Well, what I've discovered over decades is that an optimal amount of bias to apply for a woman on any given day is somewhere between 0.9 milligrams of estradiol equivalent. That's what that mGEEQ is, and I'll explain that in the seminar. Anywhere from 0.9 to 2.6. That's the optimal range of what a woman should be applying. Well, when we tested these women on 24-hour urines, 38% had titrated within that range. That was the dosage that they were actually using. And see, I hope this isn't blocking that. They were actually in the normal range. And then 7% had actually titrated below that amount of dosage, yet they had gotten alleviation of symptoms, and 54% had titrated above that 2.6 milligrams of estradiol equivalent per day. What's going on here? Well, what is the significance of 54% of the women who said they had titrated to alleviate symptoms? They had actually titrated above the optimal dosage potency range. We don't have enough data yet to know, but it probably is an absorption issue. So we need 24-hour urine hormone testing to sort it all out. So I want to compare the symptom titration data to 24-hour urine hormone testing on these women I'm talking about. And up to now, it's been all about what did they apply. Now it's going to be about what makes it into their body, as will be revealed by the 24-hour urine hormone testing. And just to give you a heads up, and I'll give you a lot of evidence for this in the actual seminar if you attend, that what I like to do is I like to add up in the 24-hour urine the sum of the amount of estradiol excreted plus the sum of estrone. I call that the total potent estrogens because they are the most potent estrogens. And I'll give you reasons why I'm saying that the optimal range is somewhere between 8 and 14 micrograms per 24 hours. So let's look at what these tests showed up on these women who titrated to happiness. Well, 27% of them were within what I would consider the optimal range, between 8 and 14. 25% of them had titrated the dosages, even though they thought they were fine. They had titrated above what I consider to be an optimal and safe range for women, above 14 micrograms for 24 hours. 13% were in lowish. They were somewhere between 6 and 8. And so that adds up to 40% were within reasonable amount of estrogens in their urine. And 35% were below the low of 6 micrograms per 24 hours. Well, just so you know, we'll accept above 14 micrograms per 24 hours. When I see that a woman is excreting more than 14, I'll find that acceptable only if their mammogram and their thermogram and their transvaginal ultrasound are normal and their family history is normal and they have no symptoms of estrogen excess. So we have criteria if they're excreting a bit more than I think is optimal in their urine. And if they go low, between 6 and 8 can be acceptable only if the vagina is healthy and the bone mineral density is normal. And, you know, below 6, I just have never seen a situation where a woman is safe. Vagina, think of that, vaginal atrophy, irritation of the urethral meatus, that without androgens, the sarcopenia of the levator ani holding up the bladder, sarcopenia of the lower extremities. I mean, this is the recipe for diapers, depends, walkers, canes, wheelchairs, the very thing that elderly women, which I have definitely have treated many elderly women, they're strong enough to accept it, but they do not like it. And some of the very best work that we can possibly do is catch these women who are low. All the emphasis in our work has been on the possible risk, and Dr. Wright and I will go deeply into the possible risk because it's the bottom line in menopause medicine. But I don't think there's been enough attention placed on the high probability of big trouble when a woman does not have enough estrogens and androgens, among other biochemicals in their body. So what does this amount to? That the potency of dosage was not a great predictor of whether they were on an optimal amount, even though you knew how much you gave them, because the amount applied is not necessarily the amount absorbed. The symptoms were not a great predictor, alleviation of symptoms. They weren't terrific as a way to predict that they were on an optimal amount. And here's my main point, that it is absolutely necessary, imperative, oh yeah, here we come. The 24-hour urine hormone test is imperative to do safe and the best menopause medicine. I'll give you more evidence for this in our actual event, should you attend. And now, what I'd like to do is Dr. Wright and I are going to trade questions to one another. And Jonathan, the first question I'd like to ask you is testosterone replacement always necessary when a man's testosterone levels are low?
Everybody seems to think that's a setup because the obvious answer is no, particularly if he's 29 years old. But getting out of 29, it's not always necessary for guys who are in their 40s or early 50s either. Now, we all know that records were kept on testosterone testing back in the 1950s. And folks have compared those records with records from, let's just say the last decade. And what do you know? The average guy's testosterone is dropping about a decade earlier than it was back in the 1950s. Gee, what's going on? Well, we all know what's going on. It's called toxic pollution. There are heavy metals, cadmium and lead will block one's testosterone. That stuff that some people are foolish enough to spray all around, called Roundup, is really murder on testosterone production. And so that's probably, very highly likely, making the testosterone go low in the younger age group. So, well, Drew is go over that with guys and say, hey, you know, you could get your own testosterone back. Now, if I'm talking to an 83-year-old, I really don't bother. But if it is somebody in their 40s or early 50s, I'll say we've got options here. And by the way, if you do discover you've got a bunch of toxins, wouldn't it be better for all the rest of your health if you got rid of them anyway? Even though the main point is de-repressing estrogen production. I'm sorry, testosterone production. It can also repress estrogens for ladies, that's for sure. And so we have to let the patient make their own choice. And many of the patients will say, I haven't got the time, just give me testosterone. Okay, it's your life. But it will help. The testosterone will help very many other things, even if we haven't got the toxins out. But there's a number who will say, no, hey, I didn't know I could make more man testosterone. And so then we'll discuss detoxification, chelation trials to see if they've got the lead and the cadmium and the other repressors. There's a good laboratory test for toxic chemicals. Very simple, just send in a urine specimen. And we know that heavy sweating is one of the major routes to getting a lot of those chemical pollutants out of our bodies, not the toxic metals necessarily so much. So anyway, that's kind of an ambivalent answer. Sometimes yes, but sometimes the guys will choose to go for detoxification and de-repression of their testosterone, get their own testosterone back. So there you go.
Yeah.
See, being as women don't have that option. After the ovaries decided it's the time to go, can't bring them back. The guys do have that option sometimes. Okay, well, I'm supposed to ask Dr. Rosensweet something. What can I think of? Well, you did mention risk about women in menopause being treated by hormones. Can you expand on that a little more?
Well, you know, every woman that's ever walked into my office, whether they say it out loud or not, there's varying degrees of concern that if we treat them with hormones, are they going to get breast cancer? And I always like to honor and address that. Of course, it's variable woman to woman, but I like to bring that topic up in the very first visit. And sure enough, there's a lot of relief for many of the women when I do bring it up. And, you know, bottom line, and we're going to give you the literature references that you can go to yourself on this, but what I would summarize the literature by saying is the real problematic one was Prempro. And it must have been that Provera. And even though there wasn't a tremendous increase of risk for breast cancer, heart attack, etc., the relative risk was 1.27 with Prempro, but even with Premarin, it was 0.79. And the best information we have about treating women with bioidenticals is the relative risk is 0.79. That's less than 1. That means a woman is better off receiving bioidentical hormone treatment than no treatment at all. And then, as I was mentioning earlier with those cases presentation, the real story as far as risk is almost the near certainty that, so many women, if they don't get treated, they're going to get osteoporosis or sarcopenia, vaginal atrophy, bladder, incontinence, cognitive issues, energy decline, libido, hair loss, mood. Well, I've already told you about it. But this is another thing that I'd like to emphasize is the near certainty of trouble if women do not restore, if most women do not restore their basic hormone levels, not to useful levels, but to decent levels. And, you know, it just doesn't take that much, which is very interesting, and we'll give you the numbers for that. I mean, how much does it take? Well, during the seminar, I'll give you the actual numbers. They happen to be at the low end, and certainly we do not need to get a woman's period to come back. Way too much estrogen. So, now I'd like to ask you a question, Dr. Wright.
I hope
Here you go. Good luck.
Thank you.
After the decision to replace testosterone is made, what are some of the things to watch out for?
Okay. One of those case studies covered one of the main things, 1 in 3 guys. Watch out for that hyper-aromatization. And remember, since we can't get the serum-free estrogens, we've got to do it in a 24 urine test. Okay, that's one of the main things. What are the other ones? Well, for some guys, the testosterone, and not all, and it's not even a third. I'd say it's down around 10 to 15% in what I've seen. But anyway, the testosterone will be accompanied by a rise in the hemoglobin hematocrit. And, of course, that's making the blood thicker. And for those who haven't seen, and I'm really suspecting that most of our listeners have, Dr. Rosensweet, haven't seen the work of Dr. Kenneth Kinsey, it appears that far more important than cholesterol levels in the blood, those are secondary, is the thickness of the blood viscosity, setting up inflammation at the branch points of the arteries, and then the cholesterol is secondary. It's pasted over that inflammation. And if the blood stays too thick for a long time, I'm sorry, we pay so much cholesterol we clog our arteries, and we have a heart attack or stroke. But the major cause was not the cholesterol. It was the thickness of the blood. So anyway, we want to run a follow-up CDC on these guys and make sure that they're not getting their hemoglobins and hematocrits, particularly the hematocrit, too high, because hematocrit is 50% of the thickness of the blood, approximately, not right on 50%, but approximately. And the more red cells, the thicker the blood, and the more chance of atherosclerotic inflammation, or I should say viscosity-induced inflammation. And for those who haven't heard about it, I'll be doing just a little book review on Dr. Kinsey's book called The Origin of Atherosclerosis. I'd say those are the two main things, Dr. Rosensweet, is watch out for hyper-aromatization and watch out for the hemoglobin hematocrit rising. Now, the other thing is I always have to remind the guys, no, we are not shooting for an 18-year-old level of testosterone. Excuse us. You probably drive your wife or your lady friend nuts with that. What we're shooting for is the Jack Benny level. And for those who haven't heard of the Jack Benny level, the Jack Benny theory of medicine is he was always 39, because that is a very good amount of testosterone if you're a healthy 39-year-old guy in the 1950s. Got your testosterone derepressed. So we're really shooting for that, and we try not to overdo it. And there we are.
Yeah.
Okay, so I guess I better ask you one since we're going back and forth here. If there are three of us, we could go back and forth and fifth, I guess. Okay, let's see. When you consult with physicians and nurse practitioners, what are some of the things that you hear about a lot that they're having to deal with?
Well, one of the biggest errors that they make, and a lot of them do not know it, is they're putting what I would women on levels of estrogens that are too high. They're way above what a woman needs, and the way that they find out that they're on too much is they eventually learn how to do the 24-hour urine hormone test and embrace it like manna from heaven, because, my God, it's one of the biggest gifts that I've ever had in treating women in menopause. So overdosing is one of the issues. And there's some of our colleagues that have even gone over to way overdosing, and they may not know it either. And because there's protocols in which you restore a woman's period, and my goodness, the levels of estrogens it takes to do that is up anywhere between 3 and 8 times the upper limit of normal of a young woman. Now, why is that so? I mean, wouldn't it just take normalizing to youthful levels? No. Menopause and periods have a lot more to do than just youthful levels of estrogens, for example, to form that endometrial lining. So that's an error that a small number are making, but I always like to help them get back on track with that one. Another major error that's being made is that doctors and nurse practitioners are underdosing. And one of the ways that they can be fooled is that a woman can feel better. Yet the real issue is, and that's good, but do they actually have enough to protect the bones, to protect the muscles from sarcopenia, to protect the vagina from atrophy, to protect the bladder? And below a certain amount that I mentioned earlier, those women are at risk for all those rough issues of the elderly. And so how do you protect from that ultimately? And that's what I was trying to illustrate in my cases presentation, is that your golden way to protect yourself there is to learn how to do the 24-hour urine hormone test, because, oh, this might be controversial, but hey, listen, we're happy to talk about it during the seminar. But I assert at this point at least that this is the only way that you're going to catch these women who are too high and too low. And then another issue that some of our more experienced practitioners get into is that as they start altering the dose of the ratio of biased from 80-20 to 70-30 to 60-40, for whatever reasons they might do that, there are good reasons to do that, and I'll go into depth in my presentation at the seminar. But if you do that just shooting from the hip, what many don't realize is that add a little bit to the ratio, for example, taking it from 80-20 to 60-40. That means you've raised the amount of estradiol. Well, you really increase the dose, the potency, the milligrams of estradiol equivalent that you're administering. So that one should be worked with by those of you who have got really good testing data in front of you. And we have a method and spreadsheets and calculation sheets that will really help you make increments of increase of dosage when you change the ratio not so intense. So you don't wind up doubling the dose. You didn't even know that it got that intense. There's math behind it all, and one of the things I'm going to teach in the seminar is that. And then one of the simplest things, and I think a lot of physicians and nurse practitioners are not making this error, but this error is being made just often enough that I want to mention it on this webinar. And is we really want the women to stop all their hormones once a month. It is, and we have a protocol to do that, and how long they stop, and I'll elaborate in the seminar. But what it does is it prevents, you know, if you take one molecule more of estrogen a month, and that's all you're taking, you're not going to necessarily notice it. But sooner or later, because the body bioaccumulates these fat-soluble hormones, you're going to be in estrogen excess. So stopping month to month, and especially how we suggest that women do that, it's going to protect us from continuing to accumulate estrogens in their body. Once a month stoppage. There's other errors. This will be plenty for now. And,
okay, but Dr. Rosensweet, may I throw in there that one or the other of us will have a PowerPoint with a citation to a European study of 133,000 women, and the women who did not take that once-a-month pause in their hormones had 44% more breast cancer risk over, I believe it was a decade of study.
Phenomenal citation.
Yeah, and we'll have it at the seminar.
That's phenomenal. Yeah, that's great. So I got one for you.
Uh-oh.
See if you can possibly answer this.
Okay.
What are the common symptoms that women need more testosterone?
Oh, I didn't answer that. My medical assistant did. You pulled a trick on me here, David. Yes, she did. Let's see. This was in the relatively early days of hormone replacement, probably in the early 90s. That medical assistant altogether, she and I worked together for a little over 20 years, and then she had to move back to take care of her mom in New Jersey, and we're in Washington State, so that was that. But after about 4 or 5 years of hormone replacement with women, comprehensive now, that means not just estrogen, progesterone, but also testosterone for those who need it, and the thyroid and so on and so on. Anyway, she told me, I can always tell when those women have enough androgens, even when I don't have a test. I said, come on, how can you tell if they don't have enough androgens, especially if the test hasn't come back from the lab yet? She says, the women who have enough androgens quit calling me all the time. The women who have less than the female normal for estrogens, they call me up a lot. So it appears to have something to do with anxiety, not having androgens. Now, I won't tell you that's the only thing, but that's one of the best ways of telling. And I started paying attention to that, asking some husbands some questions, and sure enough, when their wives got on to sufficient testosterone for a woman, not too much for a woman, or certainly not into a male range, but when they got it back into enough for a woman, oh my goodness, their husband said they weren't as nervous and anxious. Now, it didn't apply to everybody, but to most. So there you are, sir.
If I might add to that, one of the surprises for me, especially since I was testing every single woman early on, even before I started treating them, I no longer do that, but one of the things that I saw is that many women, as they entered menopause or were in the perimenopause, even though their estrogens, progesterone had tanked, some of them, and I'd guess it was about 30% in my practice, had some decent androgens. And then what I learned over the course of years is, my God, 3, 4, 5 years out, I found in my practice and through all the testing that I did is that these women androgens decline as well, and it's very, very rare for me to find a woman with decent estrogens 2, 3, 4 years out into the actual menopause. So keep your eye on that one because it's a deal. They're going to run out of those as well.
Certainly are, and I agree with your observation there, David. It's not necessarily the very first thing that goes down, but ultimately it does.
And, here's a question for you around that one. I mean, is this a newer phenomena? It seems to me that these androgens that are depleted in women in the perimenopause and the early menopause, they often have stories of very substantial stress. And I don't know if this is a newer phenomena, but geez, I seem to see more and more of androgen depletion. And sure enough, if I start listening to their life story, there's been quite a bit of stress in there because the corticosteroids are going to be preserved. This is the highest priority for the body in the hierarchy of hormones. But my goodness, if there's too much stress, it's going to go after that estrogen. The body's going to go after the androgens because they're very empowering for fight or flight. Is this your experience as well?
Mostly, yes. And although we're partially theorizing here with all the stress, even though I hear you, we both observe that. Of course, if you're going to have to make more corticosteroids, where are they made? The adrenal cortex. And is the adrenal cortex going to have the, quote, energy, unquote, to pump out all the adrenal androgens? It's not just testosterone here. DHEA levels are also dropping more rapidly than they did in the past. And DHEA is the adrenal androgen. And my medical assistant was referring to both androgens when she was referring to them, both the testosterone and the DHEA.
Absolutely, and I meant to as well. It wasn't just the testosterone that drops. And on our screen right now, you may see a photo of two people who aren't Dr. Wright and I, but as Dr. Wright wanted to point out, they're far more beautiful than we are. So we want to keep them up on the screen.
Yeah,
these are our beloved.
We'd get bored with us.
Looking at them. But just for fun, here was the same day of Dr. Wright and I. Okay.
Okay. Drs. Wright and Dr. Rosensweet, we do have a couple questions, and we can answer these before we close within the next 10 or 15 minutes or so. The first question, do you prefer saliva or urine testing for hormones?
David, you want to do that one, and then I'll follow
Do you want to do that one?
No, you do it.
Well, you know what? Here's what happened to me. I was very open to saliva testing early on when I first started working with women in menopause. It actually seemed to be a less cumbersome test for women to do at home, and it was cheaper. And so I started out with them, and, I was getting these tremendously discrepant results. Because clinically, they were speaking to me very loudly through the symptoms they were having. But my goodness, when I would look at the salivary results, I was puzzled. Well, early on, a dear colleague of mine said, you've got to do 24-hour urine. So I was actually only doing salivas for a very brief period of time. And what I saw is the 24-hour urines reflected just perfectly to me exactly what was going on clinically with a woman. So I abandoned salivary testing. Occasionally I'll do it for temporal cortisol output, meaning a 4-point saliva, because the cortisol is abundant enough that it will show up in the saliva. I don't think it's a perfect way to test, but in fact, I do those very rarely because the 24-hour urines are so revealing about the corticosteroids, everything that I want to know about them. But I'm heavily biased here.
Well, when I'm biased, Dr. Rosensweet, we have evidence. There's a Dr. Leschelin who published a study showing that while endogenous progesterone could be very accurately measured in saliva, exogenously administered, progesterone was highly variable and did not reflect what they were taking at all. I'll have those PowerPoints at the seminar. There are other researchers who have found the same thing, that salivary hormones, if they're endogenous, are fairly accurate. But if they're coming from the outside, forget it. You can't believe them. And that is the consensus of the researchers out there. There's not that many researchers, but that is the consensus.
Absolutely. Giselle, did you have another question for us from the viewers?
Yes, another general one. It says which lab. So which labs do you use?
Are we allowed to answer that?
Yes.
Yeah, well,
yes, this is non-CME.
Well, even though it's not CME, I'll just let everyone know that I do happen to be medical director of Meridian Valley Laboratory, have been since it was started, and that was 1976. Well, in 1982 or 82 probably, when a lady told me that she wasn't a horse and she would like hormones identical to what was in her body when she was younger. And that's actually what got the whole ball rolling on bioidentical hormone replacement, is this woman telling me she wasn't a horse. Okay, going clear back to then. Now, where was I? That lady with the horse amused me so much. What was the question again, ma'am?
What laboratory should you use?
Oh, yes, director of Meridian Valley Lab. Well, I insisted at that point that we were going to keep this therapy as safe as we possibly could, and to do that we had to have totally the best laboratory testing that Meridian Valley Lab could do. And when I'm saying I insisted we keep it safe, this is slightly off the topic, but I read all the work of Henry Lemon, who proved to us that the ratio of estriol to the estrogen and estradiol told us whether the person was tilted towards or away from breast cancer. So I insisted that we always put more estriol into our hormone formulations, because that would keep the women safe. But I also wanted to monitor them safely, and after looking around at what was available, we started up with the 24-hour urines, and I understand that there is that dry urine testing out there, and yes, it's more convenient again, but it does not give us the same best results as the 24-hour urine does. So anyway, I'm medical director of Meridian Valley Lab, and yes, I send all the tests there. And that's that. Dr. Rosensweet, sir.
And there is another lab that I also use, and it's Rhine Lab. And to me, Meridian Valley and Rhine are state-of-the-art.
Okay. And one last question. Can you suggest supplements for estrogen dominance?
Let's see. Shall we both talk at once here?
Well, you're doing more on the ladies' side. I am bringing in quite a bit of information about ladies' health, but you're doing more on that side, so you get to start first.
Well, with estrogen dominance, my first thought is not what supplement can I administer. I want to know what are some of the causes. If you're dealing with a woman in menopause that's being treated, you want to get an accurate read on those dosages, and you want to be certain that you have adequate progesterone to balance that estrogen. Now, estrogen dominance can happen much earlier than being treatment in menopause, and it's in fact, these days, I mean, when I was in medical school, we were taught that the onset of cessation of ovulation occurred at the same time as the cessation of menstruation at menopause, somewhere between 45, somewhere around 45 years old, up to the 50s. But nowadays, the cessation of ovulation can occur up to 10 to 15 years earlier. My goodness, what's happened to women on Earth in this period of time? And as you all know, that in order to produce the robust amounts of progesterone that come out in every cycle, you have to ovulate. And if you don't, you're left with a very small amount, minuscule amount compared to the amount that comes out of the ovary with ovulation of progesterone. So one of the more common causes of estrogen dominance in a younger woman is, oh my goodness, she's not ovulating, or she's ovulating irregularly. And then a third thing to look at is in this day and age, it turns out that a woman can decline in the amount of progesterone that she is excreting in relationship to estrogen, both earlier and more dramatically. In other words, you'd think over time, probably from the mid-20s plus or minus, that estrogen and progesterone amounts would decline sort of in tandem, sort of in the same ratio, but they don't. One of the clinical findings is, and the testing findings, is that progesterone amounts in relationship to the amount of estrogen tend to decline earlier and more profoundly. So young women can get into estrogen dominance, and if it's that situation and there's not other issues involved, that's a wonderful time to start a woman on transdermal progesterone, or whatever form it takes to get adequate progesterone into her body. I think we could do so much good on the planet if we, number one, could educate women, and boy, Dr. Wright and I are sure trying to do this, that they can start having progesterone deficiency in their mid-30s or even earlier. And if they'll just take a little dab will do it at that age, just to catch up, to balance the estrogen and progesterone. And that's one of the best things we could do for women, is to keep that progesterone up to balance that estrogen, because we don't want overstimulation of breast glandular tissue, for example, by excessive amounts of estrogen. Then, there are more causes, and sometimes you've got to look at, are they processing these estrogens properly? So we get into issues with the liver, and my goodness, people decline in their liver's ability to do a lot of things, including process the estrogens. But those are the major ones I want to mention, that in the mid-30s, progesterone could be relatively less than estrogen, and you should just start treating with progesterone. And the other reasons that I mentioned, especially when ovulation stops, then you really want to get adequate progesterone in there to balance that estrogen. And then in menopause, you got to look out that you're getting, and testing will reveal that, and that when you're treating women, you will. Go ahead, Jonathan.
Okay. Well, actually, we can bring supplements in. This is a similar situation to the, relatively speaking, younger men whose testosterone levels are dropped. And the question here is, do we want to just have some testosterone prescription, or do we want to get those younger men back on track making their own testosterone? And as I mentioned, many men will take the option, particularly if they're in their 40s, of trying to get their own testosterone back. All right, well, that same option can be given to women. There is a very good study on ground flaxseed, of all things, and ground flaxseed, I've forgotten the dose, it'll likely be in the seminar somewhere in one of the PowerPoints. Ground flaxseed was found to restore ovulatory cycles and help a woman have many fewer anovulatory cycles, just ground flaxseed. Now, it has to be fresh ground, and as we know, it oxidizes relatively rapidly. So very fortunately, enough companies know this, that they sell it in very small packets, so that here's your one packet is a daily dose, and it doesn't oxidize until you open the packet. So women can restore ovulation with that. Secondly, there's a botanical out there called Vitex. I know everybody's heard of this one, but Vitex does stimulate LH, no question, and LH is the progesterone stimulator. And then I'll go right back to those guys. I'll ask these young ladies, it could be that this has something to do with all the chemicals in our environment. How about some detox? You and your husband could climb into that sauna and sweat like mad and then have some fun later. But that sweating will get some of those toxins out that just maybe, and here I don't have the science on it like the science exists on the ground flaxseed and the Vitex, but it's very much talked about that all the environmental chemicals are messing with women. Dr. Rosensweet, you just definitely accurately pointed out that women are having problems with their hormones, just as men are, at least a decade earlier on the average. And so a bit of detox, plus some Vitex, plus some ground flaxseed has helped to restore the balance without having to use any exogenous hormone yet. But there are those ladies who say, no, just like the guys, I don't have the time to go detox, and I don't want to take a lot of supplements. fine. Here comes the progesterone. It's not going to hurt him any, is it?
And then the story can get bigger and deeper. I mean, very often the elephant in the room is they're activating the biology of the stress response in a very intense way. And, you know, every hormone available is going to be called to the fight or flight front line, including estrogen. And so you can send estrogen down the stress pathways and get high levels in young women. And then, yes, as we started to open up the very significant thing around detox, and then you can ask the question, well, how did their livers get that way? Yes, oh my goodness, the environmental chemicals, and also what's going on in the gut. So it can take us down this pathway that we all love and have gotten into holistic and functional medicine because the knee bone is connected to the thigh bone. So find out why that estrogen dominance is there. There was a reason for it. Well, I have another question for you, Dr. Wright.
Okay, I'm still here.
Is it really possible to reverse Graves' disease and the elevations of the thyroid hormones within 2 or 3 weeks?
Another softball question. I love it, David. Thank you, Dr. Rosensweet, for the nice softball questions. And what I've got to say is absolutely so. But by the way, that's not me making it up. It's Walter Reed Army Hospital, a publication in the mid-1980s, and they were doing that, and all I did was copy them, and oh my gosh, it works in nearly every case within 2 or 3 weeks. Reverse that high T4, that high free T3, and bring the TSH back, which comes back because the high free T4 is going down, as we all know. It's very possible in 2 or 3 weeks I'll have a series of PowerPoints that shows where it was and where it went to within 2 or 3 weeks. And then I'll have the one case, and I really do mean this, everyone who's still with us, if you can put up with this, the one case since that publication came out from Walter Reed Army Hospital in which that treatment failed. And that's one out of, in all these years, probably 50 or 60 now. The one case in which it failed, and guess what? We got that one better after we'd observed that treatment fail in 2 or 3 weeks with a second treatment. And that knocked that poor Graves lady into hypothyroidism, and we had to back off the second treatment, which happens to be a very safe one, but we had to back it off pretty quick because she didn't like being hypothyroid any more than she liked being in the Graves disease category.
What a miracle that is for any of us who've ever had someone who was super hyperthyroid. What a blessing to take that thyroid into normalcy. My goodness.
Yeah, Walter Reed Army Hospital again, not me.
Okay, one last question for the evening, and then we'll wrap up. It's regarding measuring hormones. It says, urine measurement is for looking at metabolites, but what do the doctors suggest to measure hormone levels, blood, serum, etc.?
Okay, urine levels are not just for looking at metabolites. Come on, folks. You can check free testosterone in the urine. You can check free of all the estrogens, and the principal estrogens as well as the metabolites. You can check them all right in the urine, but with blood, there you can measure testosterone and free testosterone. So sometimes I'll just do that if I'm pretty sure this guy is not a hyper-aromatizer. Remember that. I need my estrogens to judge the hyper-aromatization. But let's say there's absolutely no family history. He's not obese, nothing like that. Fine, do the testosterone, free testosterone. But blood for estrogens, excuse me, I know of only one laboratory in all these United States which does serum-free estradiol. And they are very, very high priced. They're somewhere in Southern California, and maybe one of the major laboratories has started doing that. But as Dr. Long Cope, and you will see the citation and his conclusion, as Dr. Long Cope pointed out, the half-life of estriol, which is the very important anti-carcinogenic estrogen, as the doctor taught us long ago, we want more estriol than the sum of the other two estrogens. You cannot measure serum-free estriol because the stuff has a serum half-life of between 4 minutes and an hour and 8 minutes or something like that. And after that, it's gone. So how are you going to measure it? I'm sorry. I get a little excited about that, but
no kidding.
Pre-estrogens in urine. You got to do the urine. In blood. You just can't do it. And I know I'm asking the Seattle City Council, which is inclined this way, to pass a resolution against laboratories just doing free testosterone and not doing free estrogens. But even the Seattle City Council can't get around Dr. Longcope's research findings.
And then the other thing, the very first things that appear on 24-hour urines are those total potent estrogens. That's estradiol and estrone. So my goodness, we sure are looking at the parent hormones of the estrogens and, of course, all the metabolites in addition to that. And then the androgens, we're looking at free, as Dr. Wright just said, free testosterone and DHEA, and then the androgen metabolites. Then we're looking at the metabolite of progesterone, which is the best way to assess progesterone because it's metabolized so quickly, and then also the corticosteroids, cortisol being the principal. And then a part of the deal is when you're actually treating a woman in menopause, and my goodness, one of the most important things that I can possibly learn about a woman that I'm treating is what are the real-time dosages, how are they translating into her body, what kind of levels are we achieving in her body? Well, if you try and do a serum one, you've got to deal with peaks and troughs. You've got to get the timing down of each individual woman. What are you going to test? When she peaks, are you going to choose a arbitrary 2-hour or 1 hour after she's actually taking her hormones? And it's so cost prohibitive to measure estrone and estradiol by blood, not to even mention the timing issue. The 24-hour urine takes care of all of that. So in women that you're treating in menopause, you want to do that 24-hour urine because you'll get a real view of how much is getting into their body.
Well, let me mention one other thing you can't measure in blood that is so important. We don't hear about it because some patent medicine company is trying to get it approved by the FDA, but there is an entirely endogenous hormone called 2-methoxyestradiol, which even the Mayo Clinic in one of their publications said was a profoundly anti-carcinogenic estrogen metabolite. You can't get that measured in blood. You can get it measured in urine, and the woman's body can be persuaded to make more of that 2-methoxyestradiol metabolite, and as she does, it obviously is going to lower her risk of cancer if it's a profound anti-carcinogen, and you can't measure it in blood. So that's another reason for sticking with the urine test, because all women, particularly premenopausal women in this case, should know what their 2-methoxyestradiol is, and if it isn't up within the optimal range, they can do something about that to get it there.
Oh, yeah.
All right, wonderful. Thank you both so much for your time and for sharing your expertise with us this evening, and thank you for everyone who hopped on the webinar tonight. As a special offer for participating and joining us, we are offering $100 off if you register for the December workshop with Drs. Wright and Rosensweet within the next 48 hours. So to register, please contact Lindsay General at 561-777-6807 or email her at lindsay@a4m.com. To learn more about the World Congress and as well as Dr. Wright and Rosensweet's workshop on the 17th of December, you can visit our website at a4m.com. So we at A4M/MMI hope to see you all there. Thank you again so much, everyone, and have a great evening.
Thank you, Giselle, and thank you, everyone.
Thank you, Giselle. Thank you. Bye now.
All right. Goodbye.
Bye-bye now.